Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, Anita Finley.
This is a subject which for years no one talked about, but now we know how important it is, and we're very fortunate to have Dr. Himabala Ghanta, who's a colon rectal surgeon over at Broward Health Imperial Point, here to tell us all about what happens when you have colon and rectal surgeries, or let's do something to prevent it ahead of time, right?
Yes, that's exactly right.
So you have a very interesting history. Maybe you ought to just share that with our listening audiences. I mean, coming from India as a young woman, a girl, how old were you when you came?
I was 6 years old when I came to New Jersey.
Okay, so 6 years old, you already knew what was going on.
I didn't realize I did, but I'm sure my father feels differently after the way I used to talk to him as a young child. So.
And it's interesting, you do not have an Indian accent at all.
I do not. I have usually, if some people feel I have a Jersey accent, but definitely the Jersey attitude, which I'm quite proud of.
Yeah, but do your parents have the Indian accent?
Yes, they do.
And
and it's actually not as strong as you would think. I think partly because they've been here for the last 30-something years, and so you kind of grow out of certain things. And, of course, as they learn English, my father knew English before he got here, but my mother learned it when she came here. So depending on who's teaching you, I think you also learn it that way as well. So.
Oh, that's a good point. Well, let's just get into this whole field. And I guess I always like to ask physicians why they chose a certain field. So let's start with that. So you decide you wanted to become a doctor. And then what happened next?
I actually had known early on that I did want to become a physician. At the time, I never really thought about what kind of doctor. I just figured maybe family practice, maybe pediatrics. I knew my pediatrician was wonderful growing up. And so once I actually started my rotations, it turned out that my first rotation in med school, as far as clinicals, was surgery. So the first day, I had one surgery where it was minimal blood loss, and I almost fainted. So I wasn't exactly sure how I was going to do 3 months of that. And then about 24 hours later, I saw probably the bloodiest surgery that exists. And at that time, that was about 3:30 in the morning, and I realized I was hungry. So at that point, I figured, you know what? Maybe I can do this.
Oh, I would say so, especially not wanting to eat a hamburger or something with red meat, right?
So, and it turned out that I did finish that rotation, loved it. I went through all my rotations, kept an open mind, but at the end, when I kind of had to decide what I would actually decide for my career, surgery came out number one.
It's okay to say that, but then we have to move further. Now you even have another specialty. So when you're going through internship, do you have to decide a particular specialty, or you could just be a general surgeon?
Yes, so you can actually be a general surgeon. You go through the same training regardless. So you do, for me, it was 5 years as far as general surgery. When I was about second year or third year, really second year, you start to rotate with all of the different specialists, the vascular surgeons, the thoracic surgeons, and I was very lucky. I had a wonderful residency in New Jersey with wonderful, wonderful teachers, and I realized that colorectal surgery seemed the surgeon that I worked with, and it was a female, and with 2 male partners, and so I started thinking about it and realizing that she seems to be happy with her job. She was actually married. She was essentially going to have kids, and this is something that I thought about because at this age, that was something in my future. I was not married yet. I did not have kids yet. And knowing that that was something that was definitely what I wanted, I tried to see how I could meld my professional life with personal life. And looking into that specialty, it was something that was definitely important for females to get into because it's not a subject that's talked about a lot. And I joke around that I have small hands, so that makes it a lot easier for patients to feel comfortable when they see me. And I realized for quality of life, eventually I could narrow down to smaller, simpler surgeries that were not as ridden potentially with complications if something did go wrong. And so potentially even outpatient procedures. And I could go home that evening and not stress out about every single thing that I've done, which is some things that I do now as surgeons. You never get to stop thinking about your patients. We may not be working that day. We may be on vacation, but there's never a time where I'm not constantly thinking about what colon patient I did a week ago or 3 months ago, hoping that they're okay. So it's hard to leave your work at work. So.
Well, that's a great explanation. I appreciate that, Dr. Ghanta. And as you were talking, I was thinking, yes, because if you were a gynecologist, you'd be on call all the time. But here, as a colorectal surgeon, you actually pretty much, I suppose, it's all prepared and it's all in advance. And so that's good. But Most of us have no idea how much of that, I always call it spaghetti, is inside us, right?
Right.
I mean, if you, let's just talk about it. If you actually stretched it out from here to the next room,
Yes.
how many feet
There's
is it?
actually probably between 22 to 25 feet of small intestine. And in addition to that is the colon or the large intestine, which is an additional 5 to 6 feet.
Absolutely amazing. And it, how should one take care of their colon?
The most important thing is usually a healthy diet, because what we think about is that we always want to eat healthy for our heart and our lungs and our other parts of the body, and of course weight control, which is always, especially for females, we're always thinking about that. But what we put into our body is what also comes out. And so for patients I've seen from young age to older age, they talk about how their body changes with time as well. So what they used to eat McDonald's at age 20 in high school and college was never a problem. But now you get to 40 and 50 and those foods don't agree with you as much.
Well, I'd like to stop you there because I've never asked that question. Why is that true?
And
what happens?
The fact is your body, just like everything else, it starts to go through changes. Your cells change, your DNA makeup changes to certain things that you used to tolerate. You don't tolerate as well. Our stomachs are not made to be that resilient when certain things are eaten. And so, you hear sometimes after 30, 40, 50, you realize you don't tolerate that greasy, fatty foods anymore. And that's one of the things that happens. Our body just doesn't adjust to rebounding back after, a night of this or a night of that. And as far as the colon's concerned, my biggest the thing that I advertise the most is just a healthy diet, because we want to prevent constipation and straining. It's very difficult for patients when, you don't think about these things. And if you do, you don't talk about these things. And in my line of work, there's a lot of times where I've seen for years and years patients say, oh, it was just constipation, it was just straining, that was a little bit of blood, nothing to worry about. And that always bothers me, because I tell patients when there's changes, that's what you need to worry. If you were always constipated all your life, yes, that's one thing. But at least we want to make sure when you start getting a little bit into the decades of 40s and 50s that it may not be just simply what you're eating and drinking. It could potentially be a polyp or something like that could cause these issues. And that's why we always stress colonoscopies at a certain age. We usually say age 50 as the benchmark, kind of cutoff for random population.
And then how many years after?
Now that's
if there's been nothing.
Sure, that's actually debatable. So most often we say about 7 to 10 years after, if there's been nothing found. And that's assuming there's no other new changes, there's no bleeding, no other symptoms that would make us potentially try and repeat the colonoscopy sooner. But of course, if there was any polyps, or depending on the type of polyp that was found, then we would say maybe 3 to 5 years, 5 to 7 years, depending on what the actual pathology was that we noticed.
I have so many questions. We only have half an hour. I mean, when you first asked me, what are you going to ask? I thought, I'll tell her some things, but we're never going to go there because this is such an interesting subject. I was thinking, though, about the kinds of food what you were saying. And so if one eats a lot of prunes, that's really helping to become regular as compared to some people I know who don't have bowel movements for 4 days. And I say, and I've never been like that. What do you mean you don't have a bowel movement for 4 days? Well, I don't ever. Now, why? How is that possible?
Well, this is a topic in a field that I've chose that you're forced to get very personal with people. And the truth is, it's okay if you don't have a bowel movement for 4 days. That's not a big deal if that is normal for you. So if you grew up, remember, our intestines change, and not everybody's intestines function the same way. When you read certain textbooks and you'll read, the 10 million articles on Google and everything online, it scares you sometimes to think that you may not be normal. But the truth is, some people have it once every 3 or 4 days. If it's normal for you, that is okay. But if you notice that that's changed, where you didn't have a problem, 2 years ago, but now you've noticed that these things have been changing, mostly I would attribute it to diet. Most often, more water, more fiber, ideally things to prevent the potential possibility of constipation, which then will make your intestines move slowly. But if this is something new, that's when I worry. So if you tell me you go 3 times a day, that's not bad either. So again, it depends on what we eat. Certain things run through faster. Some people will say, hey, I ate Mexican food and boy, did that hit me hard. And so, not depending on the spices or the herbs or the fact that we do certain vegetables that have lots of fiber, all those things are proponents of potentially moving things through faster through your intestines.
Well, you'll be happy to know that specifically before I came for this interview, I had a lot of edamame because that's fantastic. Yes. It's so healthy.
And very high in protein, too.
I noticed, and it's very funny. I have a little Maltese dog, and she's very particular, but boy, does she love that. And I don't think it can hurt her.
No,
it's got to be good, right?
All, exactly.
But also, I know other, I have Indian friends who, they do a lot of spices. And I really can't handle spices, but it probably would affect your colon, spices, doesn't it? So, but is it okay to eat it?
Yeah, it's perfectly fine. I mean, for some people, they can't handle spices, and it somewhat depends on how you grow up. So if you grow up eating these things, you slowly get accustomed to them. My 3-year-old right now can eat spicier food than other people I know, but that's just because he tries different things and your taste buds change. Just like if you, for instance, beer. Does anyone usually like beer the first time they taste it? No, but your taste buds change and evolve to the point where you actually like certain things and can handle certain things as well. So spicy foods is not dangerous in any way unless they start causing irritation. And some patients will notice that if they eat very acidic foods like tomatoes or orange juice or spicy foods, they start to get an upset stomach. And what happens is it is harder for the lining of the stomach to handle some of these things, in which case we tell patients, of course, slow down on certain foods that could do it, but otherwise they themselves should not be a risk for causing potential polyps or cancers, God forbid, things like that. It's not known to attribute to those kind of abnormalities.
So we've been going light and lively on this, and now because you are a surgeon, and I'm just curious about some things to do with this. So now there's a colonoscopy, and is an endoscopy the same? What was the difference in the two of them?
Technically, we use endoscopy is the same, except endoscopy. Usually, most often when we use that word, we say upper endoscopy, which means that it's basically the esophagus and the stomach. Okay, but technically, endoscopy as a whole is just looking inside something. The intestine.
All right, and you're young, so I'm going to ask you a question though. Before you went to medical school, let's say 50 years ago, how would a doctor even know if something's wrong inside?
Most often, this is where we really rely on good talking to patients. I mean, nowadays you hear a lot of times that the doctors don't give you enough time to talk. And that's true. Unfortunately, everyone's schedules are busy and it becomes a little bit difficult. The 1 hour that you may have spent with your regular doctor now becomes 20-minute appointments. But the most important thing is if you've noticed a change, that's what I always say. It's okay if you have a little bit of bleeding. It's okay if you have a little bit of constipation or a little bit of straining, if those are not new things. And at one point, relatively recently, you were checked out as far as having a colonoscopy or even just an anorectal exam. It doesn't necessarily mean we need to go straight to an invasive procedure. But if you can tell me that those things have always been there 10 years, 15 years, and at some point, depending on the age, you actually got a true evaluation to look inside and make sure there was nothing obvious to account for that, then I'm not worried. But if you get to the point where you're saying this didn't used to happen to me, that's where I start to say, let's take a better look. Let's do a more thorough history of when is it happening? Is it the certain foods you're eating? Are you taking enough fiber and water to help prevent the constipation? Because a lot of times when we get, let's say, bleeding for what I deal with on a daily basis, it may just be hemorrhoids. And what people don't realize is we are all born with them. Every single person has them. And they don't worry about that until we start to get some symptoms from it. And that's where the scare becomes. Now, do we have to do anything based on it? That's where I come in. That's where we do a physical exam and talk about when it's happening, why it's happening, and what I find, and then decide if something really needs to be done.
So now we can move. Let's just go to someone who's had a colonoscopy, and you notice there are troubling spots, areas, polyps. Yes. And then you, of course, do a biopsy, I'm sure. And then you find that it's more serious. Well, to talk about some of your patients who really had some of these problems so people who are listening can be aware of why they should have a colonoscopy.
Sure. The most important thing with the colonoscopy, and it's usually the stigma of how uncomfortable it is. And I do admit, yes, the day before is usually the most uncomfortable thing, the prep. Obviously, you're in the bathroom several times that day, some more than others. But it's usually unbelievable how important it is to get that done. By age 50, no matter what, symptoms or not, even if you're healthy as a horse, as we say, you should get it done no matter what. But now, if anyone is having some of these bowel habit changes, such as even at age 35, or if there's a family history of any cancers that could be potentially attributable to some of these changes that a patient may feel, it's very important to get it done earlier.
Before you continue, I want everyone to know, if you've just tuned in, we're having a very interesting conversation with Dr. Himabala Ghanta, and she is a colon rectal surgeon with Broward Health Imperial Point, and we're so happy to have it. We're talking about we're talking about constipation, hemorrhoids, anal fissures, and all sorts of things that most people don't talk about at dinner time. So keep going with this.
Now, we were mentioning what happens if someone gets a colonoscopy and a polyp is found. Now, I always tell patients not to get scared because there's different versions of polyps as well. And so within the versions of polyps, there's the ones that are less dangerous, which is more likely to be benign or good. And then there's the ones that are a little bit more likely to progress to a cancer. If we find a polyp, the most important thing is that we remove it. So usually we only biopsy something, which means take a piece of, only if we can't get the whole thing out. But ideally, our whole purpose is to remove it completely, send it to the pathologist. Now, if we've removed it and it shows that it's a benign polyp, then we're good. Now, if it shows that basically it could be one of the more likely polyps that could progress to cancer, then we tell the patient, okay, let's see you in about 3 to 5 years or 5 to 7 years. We start to progress them a little bit sooner to their next colonoscopy. If, unfortunately, it was found to be a cancer, now that depends on where it's located. And so there's a big difference between the colon and the rectum. Nobody would think to do that because, of course, you're not taught that. But rectal cancer is very different from colon cancer. And we actually treat them differently, and even the surgery and the location all matters as far as what procedure we do. So if it is a colon polyp or a colon cancer, then most often the best treatment is surgery to remove that portion of the colon. So we don't have to remove the entire colon, but it's basically the portion that it was found in. But that also depends on what type of cancer and, unfortunately, if it has spread anywhere else. So before we do surgery, we usually do a whole workup with blood work, CAT scans, x-rays, PET scans, these radiology tests basically to see if we can evaluate whether the cancer has spread anywhere else in the body. Hopefully we've caught it early, which is the whole reason we stress to have a colonoscopy done, because ideally if it's just a polyp when it's found, then we prevent it from turning into a cancer. And if it is found to be a cancer and the rest of the workup shows that there's no reason not to go for surgery, obviously having a thorough discussion with the patient and the family as far as what to expect during the surgery and after the surgery for recovery, then we actually plan to go ahead and remove that portion of the colon.
When you say remove the portion of the colon, so you're actually clipping out the piece where that's cancer, assuming it hasn't spread, and it puts it together, and it shouldn't be a problem. There's no bag that you have to have. It's strictly, it grows back together again.
It doesn't grow back, but it will actually be put back together. So what happens is, I describe it to my patients as pipes in your house. So we have a pipe, we're going to cut a piece out and weld the ends back together. So we're not making it longer, we're actually making it shorter. It will never grow back because you were born with what you have. However, your body can function amazingly without a portion of it or even all of it. And for different reasons, I've had to remove the entire colon in the patients. And not necessarily, they do not get a bag always. But unfortunately, that gets to be a little bit more complicated because once we're missing our colon, the body adjusts differently. So I tell people, picture a pipe in your house. If you open the faucet and take out 3 feet of it, that water's going to come out a lot faster, a lot sooner. And that's what happens with our intestines, basically. So part of it is very important for the physician, the surgeon, to teach the patients what to expect. Because it's one thing that we're technicians. Technically, we are cutting it out. That's great. But that's not the hard part. The hard part is to do it properly. The hard part is to talk to the patients and the family to let them know what to expect. It's very scary to go through any surgery of any kind, but when you don't have the potential possibilities explained to you, of course, every little thing that happens after surgery, even if it's normal for you and the patient themselves, will not understand whether that's normal unless they've been described exactly things that they may go through.
And I want you to go into the rectal surgery in a minute, but I want to ask you a question. Are there support groups to help people with this?
It's very location dependent. Unfortunately, here I have not found as far as a specific area, but what I usually tend to do is, unfortunately, that's where the online resources are wonderful. And also what happens is sometimes, depending on the type of surgery and depending on the diagnosis the patient has, very few patients go through certain things. So I actually try and get them in touch with my prior patients if they're okay with it, to talk to them before and after the surgery so they could tell their life lessons as far as how they dealt with certain things. Because as much as you can talk to a surgeon about what to expect, it's never going to be the same unless you went through it. And that's true in any part of our lives, anything that we ever go through. Unless you've been through it, very hard to really describe what it feels like.
Right, and support groups are just amazingly helpful for people, especially in that area, pardon the expression, because you can't talk to most people about it, but you could talk to someone that, I had the same thing done, and it was okay, I had to be careful where I went out at night. I'm sure it becomes a little, it's funny in some of the instances. All right, so now you said that rectal cancer is very different.
So rectal cancer is different in the fact that, of course, location. So as we mentioned, your intestines are like pipes in your house. So the rectum is the last portion of it. That's basically the part right before we're at the faucet with our glass of water. So once we have to cut part of that or all of that out, that changes the dynamic of the rest of the intestines, because that was where your storage organ is. That's where you, pardon whoever's eating breakfast and drinking coffee right now, but that's basically where we're storing the poop before you're ready to evacuate it. And if we're missing part of it or all of it, then the potential to store it is gone. The other portion of the colon will try to learn it, but it's never going to function as perfectly as the way we were built when we were born. And so if we're missing that, now we have patients with, unfortunately, continence issues where they cannot get to the bathroom fast enough. They have accidents. And these are patients for different reasons, whether they're in the 30s or 80s. Our muscles don't function as well when we get older. But having said that, when we take away the actual bag to store it, then that's even more difficult. And so now, in the last 20 years or so, or even longer, really, rectal cancer has changed as far as how we treat it. We used to progress right to surgery. Anytime we found a cancer, any part of the body, surgery was it. But now we've noticed with many studies that have been done that with rectal cancer, we usually treat, depending again on the actual pathology, so every patient will be different, and they'll discuss this with their physicians, but we usually treat with chemotherapy and radiation first. And the purpose of that is to try to get local control to shrink the tumor so that when we do surgery, we have a better chance that it has not spread when we go in there to do the surgery.
So, so does this hurt at any point? I would think the rectum, because that must be very sore. You have to sit.
Yes.
And so that's a different, so it goes from mild to severe.
Right. Unfortunately, any patient that's ever had any anorectal problems will tell you that is not what they want to go through. They may wish it on their worst enemy, and that's about it. Even if it's simple things like hemorrhoids or irritation, or patients with polyps in the rectum, or, God forbid, cancer, then yes, it could be something painful. And that's where we get back to history. When we talk to the patient, what has changed? Were you hurting a month ago? Did anything happen a month ago? Did you have a fall? Did you have a recent colonoscopy that might have irritated and caused this pain or bleeding? So we always ask about when this started and what could have potentially caused it, because we don't want to jump to the worst diagnosis. We don't want to ever scare a patient saying, oh, it's going to be cancer. Of course not. That's never, ever what we jump to. But in the back of my mind, of course, I always want to rule out the worst case scenario and hope that it's something simpler that we could treat easily.
You just said something, Dr. Ghanta, about having a colonoscopy, and sometimes it could scratch, maybe, or do something that would cause bleeding. Is that common?
Yeah, it's not common, but sometimes patient will ask, is that the only thing I can do? Is that the only way to evaluate the colon? Because I really don't want to go through the bowel prep. I really don't want to go through a procedure. But truth be told, there are several different ways to evaluate. If I had a patient come in and say, listen, I'm noticing some blood in my rectum, and that's not normal. When I poop, I see some blood. So we don't jump straight to a colonoscopy. There are other tests, such as Fecal Test, where we actually test the stool, and it's called an immunohistochemical test.
I used to do those. They don't do that anymore.
They do, actually. They do.
Oh.
But what we've noticed is that it's not as sensitive. It's not as specific. So yes, if we see a little bit of blood, now sometimes patients take medications such as iron that could sometimes change the color of your stool. Iron can cause you to have black stool. And then, of course, understandably, everyone gets scared when they see that, so it doesn't mean they're bleeding, but it could be due to that. Or red meats. If some people eat a high amount of red meat, sometimes that could change the test to being positive when that's actually a false positive. And so there are other versions of endoscopy, which is, like I said, basically evaluating the inside of the intestines. There's shorter versions called sigmoidoscopy, where we only look at the rectum and the portion of the colon. However, colonoscopy is still the best test, and the reason for that is diagnostic and therapeutic. So if we find a polyp when we do a CAT scan, what can we do about that? Nothing. We say, hey, listen, I think there's a polyp. It may be a piece of stool. We're not really sure because that test is not as accurate. But with the colonoscopy, we're literally looking at it with a camera, and we're able to remove something as well, to biopsy it or remove it entirely to let us know if it is something truly to worry about.
And are polyps pretty small?
They can be. It can be extremely small, 1-2 millimeters. Remember, they start off as pinpoint. And what happens is they grow over time. Now, we don't know the exact sequence or how long it will definitely take to grow, but we normally think 7 to 10 years is how long it takes for a polyp to turn into a cancer. So that's why we use that as a gauge as far as the question, when's the next time I should get a colonoscopy? We say about 7 to 10 years, because if a new polyp will form, then we think it will take that long before it progresses into something more dangerous. So ideally, we'd like to catch it on the point where it's just a polyp and has not converted or changed its DNA makeup to become a cancerous cell.
See, that's why I was amazed that that you do allow someone to go, even if they've had no problem, 10 years. Doesn't that seem like that's too long, that something could happen in between?
Yes, you're absolutely right. And unfortunately, I've seen it where patients, 2-3 years ago had a colonoscopy and it was normal. And then next thing you know, they're coming to me with cancer. Now, those things are not normal. Thankfully, that does not happen most often. And that could also happen for a couple of reasons. One is that polyps are minute. Again, we're being as good as we can as far as physicians trying to look at the entire colon. And we're looking, literally, they go in a 360-degree view around the entire colon. So picture looking inside your pipe like, plumbers do. They're looking the whole way around every single little fold. They're trying to find any potential small polyps, 1 millimeter, 2 millimeters, 1 centimeter, 2 centimeters. Obviously, the bigger they are, the easier they are to see. So one of the disclaimers is that as good as that physician will be, they may miss small polyps. So now, 3 years later, when we find that it turned into a cancer, that tends to be more aggressive than what we would say a normal polyp would be. So that's just the genetic makeup of the patient. And we could have missed a smaller polyp that just over time grew a lot faster. Unfortunately, once something changes into a cancer, that takes over. So that grows a lot faster than just a regular benign polyp would.
So should people then be doing the fecal test once a year? I mean, it sounds... My doctor stopped that. I mean, and I just was curious why.
Right. And actually, part of it is that because it was so insensitive to be doing it, I mean, we would miss 40% of them were wrong. Yeah. So it seemed that it didn't make sense to do that. And the other thing is patient education. So when we were doing some of them, we would actually send home saying 1 sample is not enough in the doctor's office, 3 is better. So we would send it with the patients and say, bring it back. Unfortunately, the compliance wasn't very high. So now you have the physician trying to do the right thing, but unfortunately, not everybody's going to be compliant for many different reasons. And so it became to the point where it really wasn't beneficial for the patient themselves. Of course, there's always going to be the 1 or 2 patients who may catch something and find it, but it's still not probably warrant enough to do a whole routine because it, as simple as it seems, the few cents that it may be, if you think about it on a global scale throughout the entire U.S., it would be extremely expensive.
Right. Now that you explained it, it doesn't make sense. But Dr. Himabala Ghanta is a colon rectal surgeon with Broward Health, Imperial Point. And I think this morning we have heard enough about, not enough, but we've heard enough to make us understand that if there's any changes that we need to go, doesn't mean it's anything wrong, but you've just been terrific. And if anyone would like to get in touch with Dr. Ghanta, you can go to browardhealth.org/BHIP, which is Broward Health Imperial Point, or for an appointment, call 954-491-0900. And her last name is spelled Ghanta. And thank you so much.
Thank you so much for having me.